Good evening, all the aspirants present here. First of all, apologies for the all of this network issue. And today's topic is acute coronary care, which will be taken by Dr. Amrit Kaur, ma'am. She is a senior clinical fellow at St. George Hospital, London. Yes, ma'am, you can carry on. Thank you very much.
Thank you so much. Really apologies, guys. This computer is not my strongest asset. Hi, everyone. I can see we have a few people here, Akila, Omer, and hi to everyone I can't see on the screen. We'll try to keep this presentation interactive. Stop me whenever you want. This presentation is not just to present you the topic. This is made keeping in mind on how we use this care in ICU patients and how we use it for EDIC 1 as such. Remember, this exam is not a cardiology exam. This is an intensive care exam. So we only need to focus on the acute coronary care. We don't need the details of post-coronary care and long guidelines. So let's begin. This slide is just made not for the statistics, but to show you that ACS is responsible for almost 50% of the deaths responsible from cardiac causes. So that's a lot of percentage. And it is a significant 1.6 million hospital admissions. And most of them, more than half of them are because of NSTEMI and unstable angina. And less than 1/3 is from STEMI. Now, before we start, just a basic question to warm up and to just introduce ourselves. Let's start with the questions. So the first question is, what is the most common symptom of myocardial ischemia and infarction? Anyone who feels like answering it?
Fourth.
Amazing. Fourth, it's correct. It's retrosternal discomfort. Great. Second question, when would you give oxygen to a patient?
Less than 92%.
It's 90 actually on the guidelines. So close enough, 90%. Or obviously, if the patient is in respiratory distress, you would want to give it despite the saturation levels being normal. Next, what would be your time goal
10 minutes.
10 minutes.
10 minutes. Amazing. Correct. 10 minutes is great. Next, your primary treatment focus for patients with ACS. What do you want in your treatment?
Rapid reperfusion following STEM presentation.
Amazing. Perfect. The last one before we start. Which arrhythmia is the commonest caused by MI?
Number 3, ventricular fibrillation.
Amazing. Perfect. Now let's begin. Acute coronary syndrome. Keeping it the most basic, these are diagnosed on the basis of a patient coming to you with chest pain. Now we have to see if this is unstable angina, this is NSTEMI, or if it is STEMI. The first step you do an ECG. Your ECG shows ST elevation, so it is an ST elevation MI. It's sorted. The next step is if the ECG shows anything other than ST elevation, it could be a depression, it could be just T-wave inversion, it could be non-specific changes, or it could be an absolutely normal ECG. At that point, you have to decide if this is an unstable angina or an NSTEMI. What do you think is the next step to differentiate between these two?
Cardiac
enzymes.
Amazing. If the enzymes are elevated, it would be an NSTEMI. If the enzymes are normal, it would be an unstable angina. So basically, unstable angina is a diagnosis made by your history rather than any clinical investigation. The signs and symptoms. The first symptom is a chest discomfort. It is not pain, it's a discomfort. It could be tightness, it could be pressure, it could be heaviness, and it persists for a prolonged period of time, firstly, and it happens at rest. Discomfort can be associated with syncope or symptoms of heart failure. It is not only in the chest, it could be in the back, neck, jaw, arm, shoulder, and one of the questions I've seen on EDIC 1 exam, it's an epigastric pain. So to be mindful that it could be an epigastric pain. The person can also present with symptoms other than pain, where pain is not the predominant symptom. It could be dyspnea, it could be diaphoresis, it could be dizziness, it could be nausea, and it could be vomiting. So especially the elderly patients who come in with syncope, always think of MI as one of the causes for syncope or collapse. And we all know women, elderly, and patients with diabetes, they are less likely to experience chest pain as a symptom. Now, this slide is crowded, but what I want you to understand from this is patients who come with chest pain and the differentials, they can be life-threatening. So do not think chest pain as MI. Always keep your options open to the life-threatening differentials, which include aortic dissection and pericarditis. Now, it's very simple. How would you rule out an aortic dissection? You have done the ECG. What should be the next step to rule out an aortic dissection? Simple step, which would also help you rule out your pneumothorax and pneumonia. What investigation would you do?
Chest X-ray with a widened mediastinum with
Amazing. Yeah, great. And the widening of the mediastinum could be because of the bleeding from the aortic dissection. So chest X-ray would help you rule out aortic dissection. Pericarditis can be ruled out by your typical ECG findings of pericarditis. Pneumothorax, pneumonia, you see it on the chest X-ray. Pulmonary embolism, the chest X-ray will be absolutely clean. You will have a patient who's hypoxic, who can be hypotensive, who could be dyspneic, but your X-ray is clean. So you should think of pulmonary embolism as one of your differentials. GI symptoms, these are not life-threatening, but cholangitis, cholecystitis, a female, 40, fatty female can come with biliary manifestations. Keep in mind. Another one of the questions and important clinically is herpes zoster. So whenever you're examining the patient, whenever you're applying chest ECG leads on the patients, always think of herpes zoster as one of the differentials, especially because you're preparing for EDIC 1. When you come to Europe, patients come from nursing homes, not looked after very well. Herpes zoster is one of the important differentials for chest pain. And then, of course, the list goes on, but the life-threatening ones should be ruled out quickly in a timely manner. Now, anginal equivalent syndromes. We know patients who have ACS, but they do not complain of chest pains. They can come off atypical pain, which is not retrosternal. It could be dyspnea, it could be diaphoresis, MSS, as we read in the previous slide. It could also be an altered pain perception where they have pain, but they can't tell you that they're experiencing pain. These are the elderly patients, the nursing home patients, patients who have long-standing diabetes mellitus. And remember, in 10 to 30% of the cases, the most common anginal equivalent syndrome is dyspnea, which is because of pulmonary edema.